Thank you all for coming back. Hopefully everybody got a bite to eat before we jump right back into this very jam-packed schedule. I'd like to introduce Binita Kamath, Dr. Binita Kamath, and also Dr. Henry Lin. We're doing a session on transplant. We did a live Zoom session last year now. I can't believe it's already been almost a year on transplant, and we had an excellent turnout with our families and some excellent lineup of speakers. And it was just a really informative, just laid back discussion, not really a presentation, but a talk. And I think that we're just going to recreate that and just open up the discussion with a little bit of a light agenda. But really, we want to lead the discussion based on what you guys want to know. So what I would like to do is just maybe do, just an overview, Dr. Kamath and Dr. Lin, if you would just kind of introduce yourselves and then do just a light overview, maybe starting with you, Dr. Kamath, on transplant, why someone would need a transplant, things that lead up to that, and we'll just wing it.
Yeah, great. Thanks, Roberta. So yes, as Roberta was referring to, we did a session like this about a year ago for the Split, which is a transplant organization. And we realized that, we all like to talk, but sometimes there were some really specific questions that were coming from the families, and the conversation flowed really beautifully, I thought. And so we thought that we would try and recreate that. So as Roberta said, my name is Binita Kamath. I'm one of the pediatric hepatologists at Sick Kids in Toronto, but I also spent some time at CHOP, and Dr. Piccoli taught me everything that I know. So I like to think of myself as mini-me to him. And Henry, does that make you mini-mini you? Or I don't know.
Yes, but they're really, really big shoes to fill, trying to follow in yours and Dr. Piccoli's footsteps.
That's okay.
Mini-me.
So I think some of the comments that we can make about liver transplantation and Alagille syndrome, I think if we go back quite a few years, we used to write book chapters and review articles, and we used to say that overall about 20% of individuals with Alagille syndrome need a liver transplant at some point. And I think the issue with that number is that we were looking at all comers with Alagille syndrome, some that had, most of whom had liver disease, but some who didn't really have very significant liver disease. And then we realized over the time that that's probably not the best way to look at it, because if you don't have liver disease as a baby, you're not going to develop liver disease as an adult. So it's not really sensible to look at those individuals and think about whether or not they're going to need a liver transplant, because they're not. So what we then decided to do over the years is to look at patients who already had liver disease. So if you have liver disease as a baby, what are your chances of having a liver transplant? And that seems like a much more sensible way to look at it, right? And if you look at it that way, the number is higher, and it's probably more like 40% of individuals with Alagille syndrome that have liver disease as a baby will need a liver transplant. So I'll just sort of pause there for a second and put that sort of a higher number than perhaps we previously thought. And I think it speaks to what I think of as the burden of liver disease associated with Alagille syndrome, which I think is really important and really significant. And perhaps I'll just pause there and see if anybody has a question for Henry or myself. Actually, Henry, I didn't let you introduce yourself. I just started speaking. I'm so sorry.
No.
Apologize.
No problem. Well, like Binita said, my name's Henry Lin. I'm also a pediatric hepatologist, also formerly from CHOP, and worked with the transplant team there, but I've now transplanted myself out to the West Coast and at the University of through Oregon OHSU, and really happy to be working with the team out here. So that's me in a nutshell right there. Binita, I did have one question when you said that, when you mentioned children with liver disease. Is there a way to think, is there a specific definition of what liver disease is when we look at the different liver numbers, when you say someone with liver disease, or is it a pretty broad definition?
A pretty broad definition, I would say. So all the way from mild liver test abnormalities all the way to, jaundice, severe pruritus, and xanthomas. If we take all comers with some evidence of liver disease, and cholestasis. So any questions or thoughts about that number? Yeah, the chair said that you can type your questions in, but if there aren't, just to move on, I think, Roberta, you asked the question, why would a patient with Alagille syndrome need a liver transplant, right? So, and Henry, I'll let you take it away and then I can...
Assuming everyone knows here what Alagille syndrome is, then we can, yeah, go from there.
All right. Yes. I mean, that's such a good question in terms of, what are reasons why someone with Alagille syndrome would need a liver transplant? I think there's a variety of ways to look at it. First and foremost, as Binita was mentioning, is that, you do also have a pretty broad range or spectrum of involvement of the liver. Certainly sometimes, when you have worsening liver disease or your liver function can worsen. That when you get to what we call, chronic liver disease or end-stage liver disease, which essentially your liver is so irritated that it's not making or doing the things it's supposed to be doing, such as making proteins and clotting factors, that can certainly be an indication for liver transplant. Sometimes we also look at growth parameters, overall nutrition, if you're having growth failure, really bad symptoms, such as, really bad pruritus or itching. All these things could play a factor in one's quality of life, and we do know that quality of life is very important when we think about just overall health to a child, and thinking about if there are factors that impact that, such as you're itching nonstop at night, you can't get a good night's rest, that's impacting your development. Those are all potential reasons, just in a very broad way, of why someone might need a liver transplant. So I'll pause there and see if Binita has any more specifics to add from there.
No, I think that captures things really well, Henry. And I just sort of tagging on from that, I saw a question in the chat that was sort of following from your question, which is, does the worst presentation in infancy, so does the worst of those symptoms that Henry just described correlate to likelihood of transplant? So we've looked at this in a couple of ways, and we've looked at it in our Gala cohort, which is a big cohort that Shannon will be talking about later this afternoon. And we always want ways to predict, right? You have a baby with Alagille syndrome, you want us to be able to tell you, what are my chances of having a liver transplant? So one of the things that I think is interesting is that the type of genetic change you have does not predict your course of liver disease. I'm sure you've heard this already in some of the talks yesterday, but I think it's worth reiterating. So we can't look at your type of JAG1 mutation or your Notch2 mutation and say, you have an X percentage of needing a liver transplant. So that's one thing just to put on the side. But it does look like, from a couple of things that we've looked at, it does look like your bilirubin in the first year of life is probably the one lab value that has some predictive ability. And that's just associated with your burden of cholestasis and all those symptoms that Henry just mentioned. So it does seem like the higher your bilirubin is in the first year of life as an infant, that does seem to be at least statistically associated. So, it's not a perfect prediction in each individual, but it is statistically associated with an increased chance of liver transplant. That's answered the question. Yes. Is that a thumbs up? Thank you.
It's all thumbs up there.
Great. Great.
Do xanthomas, if someone has xanthomas but not itching and their xanthomas are severe, does that have any correlation at all with liver disease? I'm sorry, liver transplant?
Henry, do you want to start with that one?
Yeah, right. So xanthomas, just to make sure that we're all, just to have a definition so we're all on the same page, right? So they're cholesterol deposits that can be, anywhere on the skin, but, really at your kind of flexor extensor surfaces. So, at your knuckles, and sometimes you'll see them on the ears and things like that. So really, when you have a high burden of cholesterol, which we know that we can see that in some children with Alagille syndrome, you're more likely to get xanthomas. So it's, xanthomas alone, it doesn't necessarily, it's not a great correlation to talk about the burden of liver disease. In particular, it's really looking at just, what one's cholesterol is. Certainly when you look at it from the perspective of, the liver is also responsible for making cholesterol. There is some relationship there. But, I would say in general, I would defer to what Binita's team has been looking at through the GALA study, but it hasn't typically been something that, you can draw a direct line from, worsening burden of xanthomas equals that you are more likely to get a liver transplant. I think, usually in those cases, you have other reasons in which one might be needing a liver transplant.
And Amanda Coda does have a question also. Is there a threshold bilirubin level that when crossed increases the likelihood of transplant?
Yes, I sense that I would probably get asked that question. So I just want to make it clear that these are statistical associations that we look at, right? So and we look at them over time. So what we're doing when we're looking in a research study is we're taking hundreds of children with Alagille syndrome. We're looking at all their labs. We're looking back over 6 months, the first 6 months of life or the 12 months of life. And then we're trying to see what was the median, which is a form of an average, bilirubin in the groups, in the kids that then ended up needing a liver transplant. So I don't want to say that if you hit this number, you automatically need a transplant. So I don't want to, that's really not the message here. I would like to say that people should use this as a guide, that this increases your chance of transplants. I think it's just, I'm giving this long introduction because I don't want people to walk away. I'm going to say a number, I promise you, but I don't want people to walk away saying, I hit that number, therefore I need a liver transplant, right? That's not that. What we're talking about is a statistical association and giving us an indication of burden of liver disease. Right, so I hope that that's clear for the preface. And so what we see, it looks like it's a bilirubin of about 5. Seems to, I mean, above 10 for sure, but that's easy. Anybody would know that. But even if you're getting a bilirubin above 5 early on in life, that you are increasing your chance of needing a liver transplant. And that's total bilirubin. And again, that might not be a huge surprise to many of us because that is, a reasonably good number. But that, like, just to say again, it's not just an automatic transplant when you get there, but that's roughly the number where we start to get an increased risk. I think the other thing, sorry, go ahead.
Oh no, sorry, Benny. I was going to say, I think to add to that, right, some of the challenges is, when the bilirubin is a marker of bile flow, right? So when your bilirubin is elevated, it's saying that we're not having as good of bile flow or clearance. And that's when you can get to some of these other symptoms that we had previously mentioned about, being a marker for transplant, such as, having more bile salts deposited in your skin and making your symptoms of itching worsen. And so I think that's, Binita, that's where it's going kind of related to what you're saying, where it's not an automatic marker of transplant, but rather when you get above a certain threshold, you'll get some of these other conditions and symptoms that might push us in that direction of transplant.
That's exactly right. It's a composite of lab values and clinical symptoms that Henry described that are really important. I think the other thing, what we're seeing from the GALA study is that most of the liver transplants that are happening in Alagille syndrome, just numerically, most of them are happening pretty early in life for complications associated with cholestasis. So all those complications that we just discussed, pruritus, the sleep disturbance associated with pruritus, elevated bilirubin, fat-soluble vitamin deficiency, bone fractures, all those things that we think of as the very much associated as complications of cholestasis. And that's where the majority of the transplants are happening. However, there is a smaller group of transplants that are happening later on in childhood. And they're often in children who have, they're not jaundiced, or they don't necessarily have an elevated bilirubin, but they seem to have some, what I think of as grumbling scarring in the liver. And they have complications of portal hypertension. And so what I just explained what I mean by portal hypertension, that's just when there is an elevated blood pressure in the main blood vessels around the liver and the intestine, because there's scarring in the liver and the liver isn't flowing as easily through the liver back to the heart. So blood doesn't flow so easily, and you get complications of portal hypertension. And that's slightly different. And there's a smaller group of transplants that we sometimes think of as happening just more in school-age children, whereas the majority of transplants for complications of cholestasis are happening earlier in life, around the age of about 2.5, actually.
Susie asks, what is a normal bilirubin level in a healthy infant?
Yeah, and I think we could kind of tag that on with the following question too, with the question just about total bilirubin. And so when we say total bilirubin, right? So you're absolutely right that it's a combination of the direct and indirect bilirubin. And so it's in a crash course of what we get in medical school, right? When you think about bilirubin, it's a breakdown product from your blood cells, and when that happens, that's what we call indirect bilirubin. That bilirubin has to go to the liver to be conjugated into a form. So it's processed into a form that your body can then excrete. And once it gets processed, that's what's called the direct bilirubin. And so the total amount of bilirubin that we're looking for is, your direct, the parts that's been processed or conjugated so you can excrete, as well as the indirect, which is the pre-processed form. So usually a normal level, it will vary slightly depending on the lab in which you have it run at. But most labs, they set a cutoff around 1 or 1.2 to put that in perspective for the value that Binita was quoting earlier. So hopefully that answers the question about bilirubin.
We have a lot of comments and focus in our support groups where, and like you had mentioned earlier, Binita, there's kind of a build up to a transplant, whether it's pruritus, jaundice, other symptoms that are increasing, splenomegaly, platelet issues. But there's a fear in the community many times that suddenly the liver's just going to turn and suddenly with no warning go to transplant. I think this could kind of play into what Tara Jakes is asking here. Could you discuss the process over time, what that might look like? I know it will be different for everyone, but kind of talk about a timeline or what you watch in this timeline. And then what Tara's asking here, is there anything you can do to slow down or limit liver scarring as well?
Yeah, so let me take the first part of that, Roberta. I think it's very interesting. One of the, I think of this as a positive with Alagille syndrome is that in general, transplant is not required suddenly. And this is in broader, this is something that we can do in a planned approach. It's a thoughtful approach. And we really care to optimize the timing and take many things into consideration. And it's particularly important in Alagille syndrome because it is a multi-system disorder, right? So we have to take so many considerations. We have to think about kidneys, we have to think about the heart, we have to think about vasculature to the brain. So it is fortunate, I think, that in general, it is not an acute or it's not a sudden thing. You're not generally suddenly in the ICU requiring a liver transplant. It is an indolent, slow grumbling towards that. We certainly get to the point, and then we talk about this is the ideal window for transplantation. And that window, it's not days, it's not even weeks. That window is, I would even say, Henry, if you agree with me, that window in Alagille syndrome is months where we think this is the good time to plan for and optimize for transplant. So I hope that that reduces some fear in the community, because I'm often having discussions where I'm saying, I think we're heading towards that. I think we're heading towards, let's think about getting an up-to-date echocardiogram. Let's think about having a quick look at the kidneys, and it's a planned bidirectional discussion, and that often involves multiple subspecialists.
And is there any way you can reduce the scarring in the liver?
So the straightforward answer, I think, at the moment is we don't know yet. I will say that, and this is now we're in the land of the hypothetical, okay? So we'll be a little bit in the land of the hypothetical, and I know this is such an educated audience that I think you're ready to hear things that are not just in textbooks. I think you're ready to hear things about what we're thinking about in the community. One of the things that we think about, what we're thinking about is that will reducing bile acids somehow help the liver, may help prevent scarring? I don't know yet. Right now, the IBAT inhibitors, which you guys have heard about, and well, I'm sure we discussed again, the ASBT inhibitors, the IBAT inhibitors, are being indicated for the treatment of pruritus. So that's a symptom control. But what many of us are really interested in is, if we reduce serum bile acids, could that actually change the biology of what's happening inside the liver? I would say watch this space. I think that it's an exciting thing for us to think about, because of course it's great to improve pruritus, and that can certainly, from symptom relief, improve people's quality of life. But what would be great for our community would be if that actually changes disease biology and slows down scarring. So I don't have a definitive answer yet, but I wanted to share with you that's what some of us are thinking about, hoping for.
Amanda Coda asks one more thing about bilirubin. Is there an age that needs to be taken into consideration? I'm assuming for transplant.
Right, I think that's it. And yeah, let me just close that, and then I know that also Hannah had a question that we mustn't move past. So I think that that's why I was talking about, it's an average over the first year of life is what we're looking at, the first 6 months of life. So I think it's a statistical association. Some children's bilirubin does improve, but what I would say is that if the bilirubin is consistently above 5 in the first year of life, you're statistically more likely to need a liver transplant. That's what I can say. Okay. It doesn't mean that every single patient will need one, but you're statistically more likely to need a liver transplant than not.
Hannah?
Oh, yeah, Hannah's question, yeah.
Okay, so I have a question kind of science and statistically, and I'll do my best, not coming from a science background. Bear with me. So a while back, I had read published from Dr. Piccoli and Dr. Spinner from 2007 on interlobular bile duct loss and the connection to cytokeratin 7 like aberrant expression. And then here recently, my son was in the hospital and had to have a secondary biopsy. He had one when he was little. And I did notice that it said there were numerous, hepatocytes with CK7 abnormal expression. So I was wondering, in his study, it was a really small one, like 18 people, and compared to PFIC and other things. And all of the Alagille patients had the aberrant CK7 expression. So through clinic and patients and biopsies and stuff, is the CK7 expression abnormal because of the bile duct loss? Is that all Alagille patients? And is that abnormal CK7 expression kind of a predictor? I guess if it's not connected per se, the bile duct loss, is it a predictor of transplant? Since it has a direct correlation to the bile duct loss.
That is, that's a fabulous question. And I think that sort of, if I take the broader question from there, I think to me is that is there something that we can detect on pathology, on histopathology, be it quantifying bile ducts with cytokeratin staining or looking at, I would say, fibrosis, which is scarring? Like, can we learn something from a liver biopsy that can predict whether or not we're heading for transplant? Is that okay if I sort of paraphrase that a little bit? Because I think you've focused in on the bile ducts, which is really important, but there are other things that we can see on liver biopsies like scarring. Could that predict transplant later? There have been a couple of times a few times people have looked at this. I think that there are some indications that there may be like degree of scarring, fibrosis may help predict. I think it's difficult because a lot of these studies, either they're small, right? So small numbers, or what they've done in the Gala study, we've looked at biopsy reports, but we haven't actually looked at the biopsies. The study you're looking about actually looked at the biopsies themselves. Some other studies like the Gala study looked at biopsy reports. I would say in general, I don't think that there are good histologic predictors on liver biopsy to adequately predict transplant. It's not as good as bilirubin, I would say. And I don't think that's because they don't exist. I think we as a research community probably haven't done enough yet to really examine that. That's one part. The other thing that I'll also just say is that remember when you do a liver biopsy, you get a really, really tiny piece of the liver, and it might not tell you the full story. And I was just gonna actually, I see Stacey just put on her, I was really hoping that she could talk about this, because we really need to think about the liver as a whole. And this really speaks to Stacey's work. Maybe Stacey, I'll hand over to you at this point, because you're just in a liver biopsy, it's a tiny piece, and it may not really tell us about the whole liver. Over to you, Stacey, because I think this is your forum.
But I don't know that I need to add too much to that, but we just had, after my talk, Dr. Piccoli weighed in on also depends on what type of biopsy and where the biopsy is taken, and you get a very different picture. So there, I guess at some level, for us really to use pathology as a prediction, we need to have consensus on where they're taken and how they're taken to really develop a consistent readout. I think right now it's difficult from what exists.
Thank you. Do the changes that occur during puberty impact a damaged liver compared to an average person?
I mean, I think that's a really good question, and I think the short answer to that is it's tough to say. You know, I don't know if we have great information on that. You know, certainly we know that, you know, as one's body goes through changes with puberty, and that can certainly affect many different aspects. You know, I would say, you know, you could look at parallel populations in which, you know, you have children with other types of chronic liver disease, you know, who've been on medications to manage them, you know, thinking of populations like autoimmune hepatitis as an example. And, you know, sometimes you do see that, you know, nothing else has changed and the child has still been on the same dose of medication and things are pretty stable. And then yet, you know, you do get a increase or a flare of the liver enzymes. And assuming that, you know, we're taking the medications and everything else is stable, you know, it's quite possible that there is, you know, some of these changes are because your body is going through puberty. And that's why we do see some of these flares in the liver. You know, whether or not that's, you know, more so, you know, because your liver is damaged, or is that just part of the process of going through puberty? I think that's a great question for us to look into, and you know, something that I know that we're hoping to do as we get more information from the Alagille community.
Thank you.
But if there isn't another, I wanted just to comment on one other thing. It was a question that you'd asked me earlier about, you know, was really to think about outcomes. And I don't want to steal Shannon's thunder. Shannon, I don't know if you're going to talk about our patient graft survival in Gala, are you? But I'm just going to comment on it. So now, am I stealing your thunder?
Maybe a little bit, but that's okay.
Yeah.
I'll let you.
Yeah, I won't give numbers. I will just say that I won't give numbers, because I'll let Shannon show you the numbers in the graphs. But I do think that we talk a lot about transplant, and there is appropriately a lot of concern about transplant. I think what's different about Alagille syndrome to so many of the liver transplants we do is careful evaluation because of the multi-system nature. If you have, and I'm sure all of you will make sure your child is at a good center for this, but if you got a team, a transplant team that understands Alagille syndrome, understands its multi-system nature, addresses organ involvement in different systems, and then takes you to transplant, the outcomes are excellent. I mean, just excellent. Patient and graft survival is excellent post-liver transplantation. We are way beyond this as an experimental therapy. It's clearly standard of care, but it's more than that. The outcomes that we've seen in Alagille syndrome are really quite superb. I have to say at the front end of that, again, I reiterate though, that evaluation is key. And we know that there are some children, sadly, who particularly those that have significant, really significant cardiac disease may not be offered transplant. So perhaps the numbers in terms of patient and liver graft survival are slightly artificially elevated because they don't include the children who we don't offer transplant to, right? So I have to give that caveat. But once you're offered transplant, really, our kids do really well in this community. And I hope that that comes out as a positive message. So of course, nobody wants to get to transplant, but if you do get to transplant, there's a lot of hope for a very positive future.
Thank you. Should we move into talking about the UNOS list?
Yep.
And what is a PELD score?
Absolutely. I'm that. Henry's the boss of that.
Yeah, well, thank you, Binita. It's I think this is an absolutely such a great question, and so, you know, so many. It's hard to know where to start. So maybe we'll just start with the PELD score first. And so you have PELD and MELD scores, and you know, PELD stands for you know, the pediatric, P for pediatric, you know, model for end-stage liver disease, whereas MELD is, you know, the model for end-stage liver disease. And essentially, you know, these scoring systems were devised to really initially predict 3-month waitlist mortality. So it's a very technical term, but just, you know, hopefully saying saying if we looked at one's overall clinical picture and the things that we can objectively measure, can we try to estimate, or to our best of ability, who might need a transplant sooner based off of who has a higher risk of mortality. So in the PELD score, the pediatric end-stage liver disease score, it really looks at three main factors. That's your albumin, your total bilirubin level, and then your INR, which is a marker of clotting. So remember, your liver does produce clotting factors, so that's why, and proteins, so that's why the albumin and the INR are part of this score. The other things that they look at as well are general growth failure, and so when you take a composite of these four different aspects, right, the albumin, total bilirubin, INR, and growth, they assign different weights to these values. And I think this is probably one of the hardest things to see, from a clinical standpoint, because when you get to the point of saying, we are considering a liver transplant, clearly your child is, has some degree of illness, and that's why we're making this recommendation. But to then have to stratify and say, well, we're going to put you in this category based off of your labs, I think that can be a difficult task. And oftentimes I think as one of the first markers we look at is the bilirubin. And for a lot of our children with cholestasis, their bilirubin levels can be pretty high. However, in the scoring system, the INR is probably the most highest weighted one, because that's the marker of liver function. And so if you think about it, if your liver is no longer functioning, your INR is going to be can be much higher, and that can be a reason to potential risk for increasing your wait list mortality right there. And so there is a little bit of disconnect where sometimes you'll say, my child's bilirubin level is going up and up, but the PELD score isn't increasing as much as I would think, and that's because they do assign different weights to it. And so the PELD score, like I said, is one way to think about how do we characterize one's liver disease severity to think about a liver transplant. But when you're thinking about getting listed for liver transplant through UNOS, there's a lot of different steps. And so each institution, each transplant institution, they have a very well set up process to go through these steps. But in general, I would say, the first step is to decide, does your child need a liver transplant? And that's going to be made with your child's Alagille specialist and the liver specialist. And then once that happens, there's usually some sort of a transplant committee. Usually that includes not only the medical physicians, but also the surgical team, because they'll want to take a look at the big picture and just make sure if there's any specific considerations. There are also financial approval that's needed. And so I don't want to get into too much details about that, but every center has a team that really focuses on the finances just to make sure that all those aspects are covered for. And then there's a large piece to the evaluation, right? So evaluation includes more than just what is the overall liver health and looking at these liver enzymes. We'll have to get imaging studies to really look at the anatomy of your liver to say, when you're thinking about a transplant, you need to do anastomoses or connections between the blood vessels and the bile ducts. And so we want to make sure that there's no what we call aberrant anatomy or a twist or a turn that we're not aware of, whether it's with your bile duct, your portal vein, your hepatic vein, or hepatic artery. In addition to imaging, we'll also, many children will go through a psychosocial assessment. It's transplant is such a big change in one's life that we want to make sure that the children and families, that we are as prepared as possible. And we know that it can put a pretty big strain, on families and children. And so making sure that we have the appropriate support systems in place prior to transplant is very important. Many times we'll also have you meet with a dietitian to look at, your overall nutritional status and be thoughtful about, what are ways or areas in which we can improve one's nutrition as we're waiting for a transplant. And then, so think of it as, you get this whole comprehensive evaluation, which you've already possibly been having to begin with. And once we, go through all of these steps, we can then list you. And there's also a whole list of transplant-specific labs that are needed in order to be listed that we would take you through. And so, I know this is a lot of information, and I'm sure there's going to be more questions with each specific piece, but I would say kind of in a nutshell, it comes down to, we decide, your medical team decides, do you need a transplant, or are we thinking about transplant on the horizon? And if so, you go through an evaluation that includes, additional blood work, some of which is used for the PELD score, imaging studies, and then a comprehensive assessment, including, meeting the surgeons, the psychologist, the dietitian, the social worker, a comprehensive team. And once you've met everyone and we have all of the appropriate labs that are needed, we can then list you, basically. And then I'll close with one piece. A final piece is, when you're thinking about listing for liver transplant, we always have to make sure that we're trying to find the best match for the liver. And so we primarily look at blood type, making sure, so we match livers by blood type to say, what blood type are you? And we look for a donor. Usually that's of similar or compatible blood type. So I'll pause there and let people digest all of that. And I don't know, Binita, if you have more to add from there.
It's such a big topic, Henry. I think you did that beautifully. I think the only piece that I would add, and you would have got to this, I'm sure, is just that the PELD score is a really valuable tool, but it's not perfect. And in practice, we all know that the PELD score quite regularly undercaptures the severity of liver disease, particularly in our patient population. So your physicians can apply for what we call exception points to bump up your numerical score. So for instance, kids with Alagille syndrome typically won't have an abnormal INR, may not have an abnormal albumin. And so, but if the pruritus is so incredibly awful, it's impacting quality of life, and you need NG tube feeds, those would be the types of reasons that your physician, they don't automatically do that. They have to write a blurb, it has to go to a sort of a regional committee, and it has to be decided upon. So you can ask your physicians what the PELD score is, if you're waiting, and then there can be discussions about, is this PELD score really an adequate reflection of what's going on with your child? Because it may not be.
Thank you. It's such an important topic. I would like to ask if you could explain what the difference between a living donor and a deceased donor is. So it's kind of a compound question. Why some institutions don't do one or the other, and then is there a success rate in one or the other that you see more frequently?
Yeah, so I mean, I can start off, and then getting to have you fill in afterwards. And so, when you're thinking about different donor types for a liver transplant, like Roberta, like you said, you have a deceased donor or a living donor. And so when we're talking about the PELD score and listing, that's putting you on a list to be eligible for deceased donors. And so, so that would includes a wide range of potential donors. When you're thinking about a living donor, what that is that, the liver is made up of different segments. And what's really fascinating about the liver is that, you only need a small segment of the liver for it to really be functional. And so what we found is that, and we know that, there's 8 segments of the liver, and if you take just a small piece, we call it the left lateral segment, or sometimes it's the left segment, or the right segment. If you just take that portion of the liver, and that could be enough, depending on size of the patient, amongst other factors, to be enough to be functional in a transplant recipient. So because of this, we know that we've learned that we can actually do living donors. And essentially, in a living donor, what it is a potential donor will be evaluated, and the surgeons do a lot of focus to say, how big is the donor liver, and then how big of a liver by volume do we think that the recipient needs? And if there is, and so there's a match there, and then they can take just a portion of that liver and transplant that in. And so, living donors, it certainly does put a little bit more of a burden on who the donor is, but sometimes, if you're on the wait list for a while, or for other personal reasons, a living donor can be a great option. And I think the key thing here is to remember that these don't have to be two processes that happen separately. When you're worked up for a liver transplant, you are automatically worked up and put on that list for a deceased donor. And you can also, we see many families who will say, well, we'd like to know what our living donor options are. And so in those cases, it would really be institution dependent. And so I think, Roberta, to answer your question in terms of, why do some institutions do living donor transplants and not, it really comes down to surgical center expertise and what is available at that center. I would say, there are probably more and more centers doing living donors now. And, in general, the outcomes are pretty comparable. No questions asked. And I think it's just, our surgical expertise and techniques have really improved over time.
Sarah has a question here too, talking about the lifespan of a transplanted liver for an ALGS patient.
Yeah, so I mean, first of all, just in general for pediatric liver transplantation, and I'm just going to highlight that this is different to kidney. When we transplant, our goal is to transplant for life, right? So that's our goal, is that the liver that you get is going to last you for your whole life. It doesn't always happen, but it is the goal. In the Garlic study, we looked at the rate of retransplantation, and it's pretty low. It's low single digits. So and those, I don't think, from what I've seen in the study, they don't seem to be higher in the Alagille syndrome community than they are in the general pediatric community for cholestatic disease. So if an individual needs a retransplant, it's typically for some transplant related, like it's a graft related reason rather than an Alagille syndrome related reason. The one other thing I just wanted to highlight with the issue of living related, so it's geographically variable and it's center variable, and this is an international community. So in Japan you can only get a living related transplant. In Canada, we did 40 transplants last year and 60% were live donor, because we don't have deceased donor availability. We just don't get deceased donor organs in Canada. So we do a lot of live donor. But the real point is, in Alagille syndrome, we don't do transplants from affected parents. Okay, now there is a little bit of data from Japan where they've said that they've done it and they said that it works out well, but that's because they don't really do deceased donor. So they don't really have the other option. In most of the Western world, we would not advocate for using an affected parent or relative, even if they didn't have any easily obvious liver disease. We would not do that, because it goes back to that philosophy that if we're transplanting for life, we're expecting the piece of liver that we're giving you to last for life. We know that that liver, if it was from an affected parent, it has a mutation in the liver. So it's not what we would call the best option for a child,
Is there an age limit on living donor for pediatrics? Is there and does it go by age, by size? How does that work?
So as Henry said, blood groups are most important. Size is important, but we do have an age. This may vary by center to center, but just because we do a lot of it, I'll say that the cutoff in our center is 50.
Okay.
I mean, that's what we typically say.
And how about for the patient? Would you do a live living donor for a young adult from a parent? Like, is there a age difference for that?
No, you can do it. It's just you cannot, that in that situation, as Henry suggested, you can't take the left lateral segment, which is this nice kind of, it's a smallish part that works really well in children and toddlers. You'd have to use the right lobe, which we do. It's marginal, not massively significant. It's a marginally increased risk to the donor, because it's a slightly bigger surgery, but it's a small increased risk. But yes, you can do it.
Okay. Thank you. Hannah has a question here. Are there any other systems or manifestations of ALGS besides cardiac that would or could affect the ability or success of transplant? I think we touched on it just a little.
Yeah, I mean, I think kidneys are really important. I think the structure of your kidneys, number one, is important. I think what we've also seen from some of the an older study that we did with the split group, where we compared liver transplantation outcomes in about 100 children with Alagille syndrome to biliary atresia. And it seems that the children with Alagille syndrome, even though they appear to have normal looking kidneys going into transplant, they do seem to have more trouble with their kidneys afterwards in relationship to the immune suppressant medications. And we know that the immune suppressant medications are what we call nephrotoxic. I mean, so that, you know, they're a little harsh on the kidneys. And we know that kids with Alagille syndrome have more difficulty with that. Again, it's not what I would say the major clinical problem. That it's not like we've got hundreds of kids with Alagille syndrome that are needing kidney transplants. That's not what I'm saying, but I'm saying that there does seem to be a sensitivity, a vulnerability. And again, it goes back to having a JAG1 defect that affects the development of the kidneys. So they may look normal, but they may not function particularly normal, especially when you challenge them with years of immune suppression.
Hey, Binita, just to add to that, or maybe a question from my end, with the GALA study and other data, do we have any information about just general nutrition going into transplant and how that might affect the outcomes or success of the transplant?
Oh, right, yes. So Henry, I haven't looked at that specifically for Alagille syndrome, but I will say one I think is really interesting thing about growth, because I think this is interesting. We know that a lot of our children in our community are on the smaller side, right? That's nothing new here, and for multiple reasons. And kids with the comparison group that we always use in these transplant studies is biliary atresia. Those kids are also small, but they're bigger than the Alagille syndrome kids. And post-transplant, when we've looked at growth, the Alagille syndrome kids are still smaller. So they come into transplant smaller and they end up smaller as compared to biliary atresia. However, if you look at growth velocity, which is catch-up growth, the Alagille syndrome kids actually get more catch-up growth than the biliary atresia kids. So I hope that hope that makes sense. What I'm saying is, even though kids with Alagille syndrome may be on the smaller side and remain on the smaller side, they can get a significant growth benefit from transplant. So I always bristle at the thought when I sometimes, I don't think it happens so much now, but I sometimes bristle at the thought when somebody may indicate to me in a transplant discussion that, oh, well, growth is not so important because all Alagille syndrome kids are growth. And that's not good enough to me, because I think transplant for a lot of kids can make them bigger than they otherwise would be. So sure, I'm not going to maybe make my little Alagille syndrome patient boy 6'4", but as a short person myself, gaining 2 or 3 additional inches in your end height, I think is a significant difference. So we don't do it just for growth, but we should consider growth an important consideration and an important benefit to liver transplantation in Alagille syndrome.
Thank you. How can families prepare for transplant? And I'm talking over a spectrum. So we have many families who are financially burdened with disease, but also preparing as far as the home, like what is the process? If you could just touch lightly on that.
Henry,
yeah. I mean, I can start, and Binita, you can fill in the gaps. But I think it's such a challenging question, right? When you think about how to prepare, because like you said, there's that financial piece, but also the overall health outcome piece, as well as your social and psychological burden. And so I think one thing that we've tried to do is really just to really involve the patient in the discussion. I think having open, honest conversations to say, this is the current state of health. This is why we're thinking about a transplant. Not to normalize the reason why you need to transplant, but at least to start gaining a shared understanding. I think that's so important because, oftentimes with our children and our patients, we may think we know what they're thinking of, but, they may have a lot of unsaid thoughts. And I think having a venue to really allow us to allow our children to really share what their concerns or fears, or maybe even what they're looking forward to is very, very important. And so I think making sure that you have that great type of psychosocial support is important. I think from a general health outcomes piece, it's always so hard because, when you're getting to transplant it by default, that means that we are a little bit sicker. And so, But anything that we can do to really try to optimize health as much as possible prior to transplant is key. And so that's going to be things like looking at overall nutrition status. Can we make sure we try our best to supplement calories? Looking at the fat-soluble vitamins, which Binita touched on briefly, but making sure that we address for any potential vitamin deficiencies is very important. And so that will include screening fat-soluble vitamins and supplementing as necessary. I think depending on the age of the child who's thinking about needing a transplant, as well as center, a lot of times now we're starting to try to do catch-up immunizations or doing an accelerated vaccine schedule because we know that after transplant, you're going to be on these immune suppression medications, and it's really going to limit the timing of which we can give you certain immunizations. And so many centers now, they have a protocol to do an accelerated vaccination schedule, especially trying to get in some of the live vaccines in which, post-transplant, when you have a live vaccine, it's really a weakened form of that infection, of that virus. And so, when you're on immune suppression, there carries a little bit higher risk of getting the infection and having some complications. And so I'll pause right there, but basically say, some pieces that we can think about preparing include, just the psychosocial aspect, the nutritional aspect, thinking about vaccination.
Thank you. Could you touch on what are some of the challenges of transplanting Alagille patients versus biliary atresia or PFIC or other cholestatic liver diseases? We often hear that vasculature is thin or weak. And so as parents, especially in the support group, we see a lot of discussion around, are the vessels like fishnets and they can't sew them up? Like, what are some of the challenges going into transplant for Alagille specifically?
Yeah, I mean, the one thing I think is really important is that if you have Alagille syndrome and you need a liver transplant, you need to be at a center that's done it there before for Alagille syndrome. It is just much more nuanced and much more complicated than it would be for straightforward biliary atresia. For that matter, I really feel strongly about that because, first of all, in your evaluation, the evaluation will be modified. So we would do, in addition to an echocardiogram, some centers, we have to say our center doesn't do it, but for instance, it's been suggested at King's that you should do a cardiac catheterization to really understand the capacity of the heart to go through a transplant. We found that we're pretty good with doing a echo and maybe a cardiac MRI, so really paying attention to the heart. We also modify our immune suppressant protocols, so we do something called a renal sparing protocol, going back to the kidneys, where we use lower levels of those nephrotoxic medications right from the beginning. And so I think taking all those things into account a priori are important. And at our center, we also do brain imaging prior to liver transplant, regardless of the age, because we want to make sure that there's nothing there that could affect a patient during a very long anesthetic. We want to, so our approach, so even before the challenges of the transplant, even before you get to the transplant, you just have to pay attention. That's the key thing. Talking about what you mentioned, the vessels themselves, it's very interesting, that multiple liver transplant surgeons said to me that the vessels just feel different in their hands. And these are surgeons who've done, many transplants. They say they can tell. But it doesn't mean that you can't get through a transplant. As I referred to earlier, and Shannon will show the numbers, patient and graft survival are excellent, but you do have to pay attention. I keep going back to this, and we do see, paying attention to the vessels afterwards. Looking at one of the complications that we all worry about is something called hepatic artery thrombosis, which is the most important blood vessel straight after a transplant, and making sure that that doesn't get a clot in it. There is, we're still trying to tease it out to see if that risk is significantly higher than biliary atresia. It seems to be a bit higher. Again, I just bet you got to have a team that understands the complexities of Alagille syndrome and is paying attention. I can't, because everybody's different, right? So, and every patient's in manifestations of Alagille syndrome are different. So it's that awareness and knowing to look out for those things. So yes, are there challenges? But if it's done in the right hands and it's done properly, I'm very positive about outcomes.
Thank you. That is a big topic of discussion a lot in our support groups, and it kind of plays in with the fear of suddenly having to go to transplant as well. I think education is so important on these areas so that families are more prepared and not so scared moving forward. Now, do you want to talk about the actual transplant itself, or should we kind of skip past it to post-transplant? We always have a lot of questions about immunosuppression. So if anybody has any questions for pre-transplant, please raise your hand, speak up, ask a question. Okay, should we move on? Do you want to skip over to kind of a post-transplant?
Let's talk about post. I think that's a really good area to focus on.
So post-transplant, again, any unique ALGS complications post-transplant, and touching on medications and also vaccine requirements post-transplant. It's kind of a big compound question, but jump in on any of that.
So I can start off with just some of the general post-transplant thoughts. And so maybe I'll start with the medications and kind of take it a chunk at a time. But when we think about post-transplant and immune suppression, the whole idea is that you want to make sure that your body accepts the liver. And so because this is not your own tissue, we have to give you immune suppression to do that. Many times, we'll start off, the immune suppression can involve a variety of different medications, but traditionally it usually includes initially, a higher dose of steroids or to really help initially your body accept the liver. And then we also use usually a calcineurin inhibitor or like tacrolimus as your primary immune suppression. I think there's probably some variations depending on center and by protocol, because each center has kind of developed a kind of slight variations on immune suppression protocols, and really just based off of their own experience, saying, how much immune suppression is the right amount, because it is a delicate balance. You don't want to give too much immune suppression, but you also don't want to give too little and have your body reject it. And so you're constantly trying to adjust the amount of immune suppression one receives. And I would say that probably in the first couple months post-transplant, that's when you see the most variation. When you're on steroids, we're trying to decrease the dose of steroids while you're still on your tacrolimus as well. And so those are probably the two main medications. Sometimes we'll add on medications like a mycophenolate to really help with immune suppression. And I would say just over your first year post-transplant, assuming that things go well, we are slowly cutting down on the amount of immune suppression that you need. You'll hear a lot of us talk about your tacrolimus level, which is basically we can measure drug levels of how much of an immune suppressant that you have. And then depending on how far out you're from the transplant, we usually have a goal level that we aim for. But I would say the big take-home point here is we're always constantly monitoring the liver numbers, looking at the liver enzymes to say, are they normal? And so while it's easy to latch on to say, is there a set number of immune suppression medications or a set level that we're aiming for, I think the key part is that, trust your medical team. And if your liver numbers are normal, we're using that as a marker to say that your liver is happy and healthy, is currently happy and healthy. And then that hopefully that means whatever amount of immune suppression that we have, that should be an appropriate amount. And so those are the main immune suppression medications. While you're on higher immune suppression medications, you'll be on different what we call prophylactic antibiotics to prevent certain infections, because we do know that when you're on higher doses of immune suppression, you're at risk for getting additional infections. And so that's pretty much medications in a nutshell. And I don't know, Binita, if you wanted to add more to that piece of it.
No, Henry, that's really comprehensive. There's a question about immune suppression drugs that just came back and just came up, and it's like, do they need to stay on for life? And that's a really interesting area of active research. That there is a recent paper that's been that's talked about in select patients being able to, and when I say select, based on patients who have normal liver labs and have normal liver histology of the graft, being able to withdraw immune suppression in a selected group. I would say that this is still happening in on a research basis in the context of a study. Henry, do you think that's fair? Like we don't systematically offer withdrawal or cessation of immune suppression in our patients in clinical practice. So yes, it's happening on a research basis, not yet prime time for the clinical world. What we do that I think has changed is that we minimize more rapidly and we minimize the levels more than we did, I would say, even 10 or 15 years ago. Do you think that's fair, Henry? I think we've really aggressively tried, every patient has that sweet spot. It's a little bit like cooking, you want to get that rest. We are trying to get to that minimum amount of immune suppression that can keep your liver happy. And that I would say is a global philosophy amongst the transplant community.
Yeah, no, absolutely. And I think it's something to keep an eye on in the coming years, just thinking about different strategies to get to that sweet spot of minimal immune suppression.
But for right now, if you're going to get a liver transplant, you should expect lifelong immune suppression. That would be what pretty much you're going to hear.
Kind of following up on that as well, can you talk a little bit about any long-term effects on other organs with the immunosuppression? And then we do see in the community once in a while when someone's on immunosuppression that they have increased allergies or sudden allergy issues that are actually quite scary, and that they have been told that it could be a result of immunosuppression. Could you talk a little bit about other illnesses that kind of go along with immunosuppression that may pop up with Alagille, or maybe that's too broad? I don't know.
I mean, I think it's that there are multiple complications of being on long-term immune suppressive therapy. I don't think that they're Alagille syndrome related. Okay. They are generally, and so, I mean, you can run through them very quickly. Infection, always affecting the kidneys, which we mentioned. The one that we worry about is something called PTLD, which is post-transplant lymphoproliferative disorder. It's a type of a lymphoma, a cancer that you can get in some patients post-transplant. The reason that I don't, we go through this when you're coming up to transplant. The one thing that I always say at the beginning and the end of this, when we go through the risks, is if you're being offered a transplant, it's because the benefits outweigh the risks. So yes, Henry and I could list out the 8 or 10 bad things that can happen to you in immune suppression, but it's almost, you need to know it if you get there, but it's not something to feel, I would say, to dwell upon at this point, because if you get to the point that you need a transplant, and then we will work as a transplant community with you to manage or to mitigate or to monitor for those side effects, but they're not so great that you shouldn't do the transplant. Right?
Thank you.
And so I don't want people to,
that's the right message to send, I think.
Right. Don't have fear for them. Don't have fear for those side effects. They're not increased in the Alagille community, the risks of immune suppression.
Thank you. Any other questions? So that's the end of our agenda. So we can just sit and talk now.
Roberta, I have a kind of a random question.
Sure.
And this is just probably too specific to my son. So my son is, he'll be 4 in September. Next month, he'll be 3 years post-transplant. So he was transplanted at 10 months old. Post-transplant, he's had pretty insignificant issues. He's never been in rejection. We go to Children's Hospital in Denver, and we absolutely adore our team and all that kind of stuff. Kind of what we're trying to figure out now, and I guess what my concern is, you had talked about that kind of big explosion of growth that kiddos can have post-transplant. he never really had that. Like he had a little bit, but he's still really tiny. And we're, like I said, almost 3 years post-transplant. So, we just did some scopes and they did a liver biopsy to make sure everything was good with that and everything's coming back okay. So I guess, our next step is probably going to be G-tube, just to help facilitate some of that growth and stuff. But is that something that you got, I guess, I don't know, this may just be I need comfort that this happens still sometimes. We thought he of course was itty bitty before transplant, but it was like, yay, he'll grow after transplant. And he has, but not even to the expectation of what Alagille's post-transplant should grow. So I guess, do you guys also run into this issue sometimes as well?
Yeah, so I would say it's always a challenge, when we run into some of these issues afterwards. And I would say the short answer is yes. We do see this. It can happen for a variety of reasons. Everything, and I think this probably speaks somewhat to the nature of Alagille, where we do know that in general we hope that the growth velocity is improved, but every child's a little bit different. I mean, we have patients who, they have oral aversion, because they were so sick before transplant. So it's just hard to get in enough calories, right? And so, it's, I would think of, your medical team, it seems like, they're really focused on, appropriately so, wanting to make sure that he gets the appropriate nutrition and calories in order to grow. And while it does sound, it can certainly be, discouraging to say, we're going backwards and getting a G-tube, or it feels like you're going backwards. I think it's all nestled in making sure that we get in enough calories so that we're able to grow and get that catch-up growth, and hopefully continue to work on just getting better. But we do see this.
Yeah, well, and I keep waiting for the Alagille's growth charts, because I'm like, maybe he'll look better on that one. Like, come on. Awesome, thank you. That's what I was figuring you guys were going to say, but I just wanted to kind of thank you.
It is tough though. It is disappointing, and I'm sure that I sense that, and I understand that. But yeah, that unfortunately some of our kids are just petite.
We have
hopefully healthy and petite. That's the other thing, right? Like with a healthy liver and petite is better than with a very cholestatic liver and petite. So that's the one thing that I would say.
Right.
So bones will be his bones will be healthier and all that kind of stuff. So I still see the positive in having gone through the transplant.
Oh yeah, no, we are transplant all the way, all day. No questions asked whatsoever. But it's just, I'm like, come on, aren't we past this?
Yeah, exactly.
Thank you.
So we have just 6 minutes left, and I want to ask if we could take a step back to biliary diversion as an option, to deal with itching. If someone is itching severely and they decided to get a biliary diversion, is it better to wait for a transplant, and maybe have medication instead, or is the option to just go for biliary diversion? Does it complicate a transplant at all? We do see some discussion about that, whether people should just wait on diversion because they don't want it to complicate a transplant down the line, or is it an indicator that a transplant could be coming if they are, severely itching, and would that be a better alternative? Where are we at as far as how do you talk to the patients about that and what their options are?
Yeah, I mean, I will just say one thing, that in the Alagille community, as compared to PFIC, people are just not getting diversions very much. They're just not. It's not now. And I don't know that I know one answer for that. Is that physician-driven, family-driven, all of it together, they're not happening very much. Doesn't mean that they haven't helped some patients, but overall, they're not happening. So that's the first thing, just to say that there's just not a ton of them happening. So it's hard to have really great experience. And even in the Gala cohort, I'm pretty impressed with 1,600 patients, how few have actually had a diversion. So that's one thing I'll say. I think honestly, With the advent of having access to IBAT inhibitors, it makes more sense to me to do a trial. You know, if pruritus is a really predominant symptom in your child's disease and you're wondering if that's a major indicator for transplant, if I had the option of an IBAT inhibitor, I would do that before a diversion. When I didn't have access to IBAT inhibitors, I absolutely offered diversion, no question about it. But now that we have access in many places, that's what I would certainly offer. And then whether or not a diversion makes a transplant more complicated, I mean, I think it varies. I've had a couple of patients who'd had a diversion for many, many years and then had other abdominal surgery, and so that there was more what we call adhesions. You can think of that as sort of scar tissue within the liver. So that can make transplant more complicated. But in general, I don't think that's a reason. Worrying about the technical aspect of your transplant surgery is not a reason not to do a diversion. I think there are other reasons not to do a diversion, like the fact that it doesn't work that well a lot of the time and it can leave you with a stoma. It's a surgery. And if you could use an IBAT inhibitor, why would you not just use an IBAT inhibitor? So, you know, that's what I would say. But if you're in a place that you don't have access to IBAT inhibitors, and I do want to be respectful of the community because they're not available everywhere yet, I hope, that I wouldn't be totally negative. And if your team is confident about offering you a diversion, perhaps, you know, it's something worth considering, but it's complicated. I'm not, they've just fallen out of fashion in many ways, I think.
And one last question. We've got about 2 minutes. People who have had Kasai, does that complicate transplant?
All right, so
gotta ask it. We have
okay. Sorry, Henry. I'm gonna do this one. If that's okay.
Yeah.
I didn't want to have, yeah. So we, from older work that we did while I was at CHOP and more recent data that we have from the Gala study. So first one, I'm just going to say, kids with Alagille syndrome, babies with Alagille syndrome sometimes get a Kasai, and it's not because your doctor's bad or your team's bad or your doctor's bad. It's happened in my practice. I have done it. Okay. And it's not because I was confused. It was because there's a diagnostic dilemma that we couldn't decipher at that time as to whether or not this was biliary atresia or Alagille syndrome. And often really in the era where we couldn't get genetics as quickly as we can now. So the one thing to have to say is that if it's happened to your child, please don't think negatively of your team, because it happens even where there are doctors and nurses who are very focused on Alagille syndrome. So that's the first thing. But if it happens, yes, I do think that it seems that the Kasai procedure itself seems to negatively impact your course afterwards, and it increases your chance of needing a liver transplantation.
Thank you very much, Dr. Henry Lin, Dr. Binita Kamath. Appreciate you joining us and speaking here. We're going to jump out of this session and move on to the Global Alagille Alliance, or GALA, discussion with Shannon Van Drill. So you'll log out of here, head back to the auditorium, and jump into that session. Thank you, guys.
Nice to see everybody.